posted it. Right. I think you have to subscribe to Dr. Mo's YouTube channel, not mine, because Dr. Mo has been uploading it. I haven't been uploading it. Okay. Yeah, the classes are mine, but yes, you have to subscribe to Dr. Mo's channel, not my channel. Okay. Right. Somebody, some other guys help him find out this one. Okay. Right. Or you can just type my name inside YouTube, and then you will be redirected to Dr. Mo's channel. Right. Should be the same thing. So let us start with our chapter today. Right. Okay. Today we are going to deal about a very interesting topic, which we have laid the foundation yesterday, but we will go a lot deeper today. This is all about recognizing atelectasis, right? So today we are going to uh, cover all the aspects of each and single segmental or each and individual lobar atelectasis, right? So most of the people who did not understand the concept of why the tracheal deviation will be on the ipsilateral side, today I think maybe you will try to actually get the complete insight of what exactly is happening in atelectasis and why the radiographic features are actually uh, the ipsilateral tracheal deviation and the ipsilateral mediastinal shift would happen in case of an atelectasis, right? So pay a little bit attention to this class because it is confusing. It is not difficult, it is just a little bit confusing, but still it is very easy if you have followed yesterday's class, right? So in this class, we are going to learn about what is atelectasis. Then we're going to learn what are the signs of atelectasis. Then we're going to look at some types of atelectasis. Well, and then again, there are patterns of collapse in lobar atelectasis, and then how a atelectasis resolves. It is like I have been always saying that radiology is not only an investigation of choice to find out the diagnosis of the disease, but also to evaluate the progression of the disease and also evaluate how the treatment protocol is working on, right? So before and after treatment, for all atelectasis cases, yes, radiology is the key, and then it is the investigation of the choice that is frequently used. So let's get into the topic, right? So common to atelectasis is generally a loss of volume in some or all of the lung, usually leading to increased density of the lung. As simple as that. Uh, Definition wise, what we can call atelectasis is that there will be a lung collapse, which eventually leads down to loss of volume. Let us say if there is a loss of a single segment, yes, we call it a segmental atelectasis, segmental collapse. If there is a single lobe involved, yes, we call it as lobar atelectasis. Or it could sometimes also involve the whole part of the lung, so we call it as hemithorax, collapse of the hemithorax. If it happens on the right side, if it happens on the left side, right? It doesn't really make a big difference in the terminology, but still it is called as atelectasis. And that is the only reason, because of this collapse of the lung, it will cause increased density of the lung. So atelectasis is one of the main reasons for an opacified hemithorax appearance. Okay, opacified hemithorax is going to happen in any kind of loss of volume due to atelectasis. It can happen in some parts of the lungs, or it can happen as a whole lung. And you can see here in this picture, I can see that the complete right hemithorax has been opacified. I can also see that the uh, shadow of the uh, right heart is completely obscured by this opacity here. Okay, the right heart shadow is completely obscured here, And at the same point of time, I can also see that the trachea has been deviated down to the right. So which suggests that the opacity is present down on the right, trachea is deviated to the right heart border is completely obscured, and I cannot see the shadow of the heart on the left side. So which means to say there is a right-sided mediastinal shift as well. So this actually shows up the complete, this actually shows the complete classical features of an atelectasis. Now, that is what the basic basic characteristic feature you have to always remember. Opacified homithorax will be there. And then at the same point of time, ipsilateral tracheal deviation will be there, and ipsilateral mediastinal shift should be present. So that is how you actually know that you are looking at a patient of atelectasis, but you are not looking at a pleural effusion or a pneumonectomy patient. So I think you remember all the things that what we have done yesterday, but we will just deal about atelectasis for today, right? The lung actually had to appear black on a chest radiograph because it contains air. That's a simple logic. You see here, look at this radiolucency that is present down on the left side of this patient. It appears black, and you can see the pulmonary markings, and I can see the bronchus intermedius and the pulmonary artery that has been showing up as a hyperdensity here, and I can see some lymph nodes. See everywhere, and this is the aortic shadow. I can look, right? So all this one is appearing somewhat like a normal lung appearance. But compared to the right is completely white, the rib shadows are completely obscured, right? But I can see the rib shadows, but still there is an opacification of the right hemithorax. Generally speaking, whenever there is a collection of the fluid or a soft density is substituted for that air, or when the air in the lung is completely resorbed by the uh, capillary absorption, right? Pulmonary capillary resorption, we call that. We learned that yesterday. And if that is happening, we call it as atelectasis. But generally, one of the causes for opacified hemithorax is that either pleural effusion, fluid fillings, or there is some kinds of a soft tissue density. And atelectasis, opacified hemithorax, is a soft tissue density that is completely causing the opacification. So remember that this is not fluid, this is a soft tissue density. And what is the soft tissue here? The soft tissue is nothing but your lung that is collapsed and completely shrinked and brought up together, or the bronchioles, all the contents of that hemithorax has brought up together because of the resorption, because of pulmonary permeability, right? So now what happens, that part of the lung becomes whiter, which we can call it as hyperdense, or also we can call it as more opaque. Okay, so let me repeat that once again. The lung has to appear black, something like this, but it doesn't appear black when it is filled by fluid or soft tissue density. In atelectasis, it is a soft tissue density because of the resorption of the air by complete shrinkage of that lung. Lung is a soft tissue, and all of the lung is brought together, so that's the reason it becomes whiter, denser, and more opaque, right? That is the first thing that happens, right? Unless mentioned otherwise, the statements are actually refers to atelectasis are referring to obstructive atelectasis. You have to understand, yesterday also I was talking, uh, I was saying that one of the most common reasons of atelectasis, of a collapse of a lung, is obstructive atelectasis. Okay, atelectasis will be happening. We saw an asthmatic patient where we had a complete opacified left hemithorax, if you can remember the picture. So that's the same way almost here also. So whenever we are looking at some kind of a picture, exclusively, if it is not mentioned, we are talking about only obstructive atelectasis, okay, which is related to mucus plugs or mucoid impaction. Okay, mucus impaction, mucus plugs. Okay, we will be talking about obstructive atelectasis in more detail. Okay, any kind of bronchus that has been obstructed by the mucus or obstructed by the mass, we will be calling it as obstructive atelectasis. So unless the reason for the atelectasis has been mentioned, we will be thinking that it is only happening because of obstructive atelectasis. That's which one I guess should cause the confusion, right? Now, first, let's start with the signs of atelectasis, right? You see here, the upper X-ray that what you are looking at here is a quite normal X-ray when compared to uh, the some kind of an opacified appearance of this lower X-ray. It is always a very good habit to look at the normal X-ray and also try to compare what are the changes that appears to be in this particular uh, X-ray. Okay, so always try to compare the pathological X-rays like this with the normals so that you can have a practice. And once you are good with normals, then it is very easy for us to recognize the abnormal X-rays. So now let us compare. You see here, the lungs are completely radiolucent, so that's the reason they are appearing blackish here. And I can see the heart shadow. The heart shadow is the right border of the heart shadow is somewhat lateral to the borders of the vertebrae. And here also, I can see that the left heart shadow is also lateral to the left vertebral borders, right? And then I can see the hemidiaphragmatic shadow are quite clear. The costophrenic recesses are quite clear, right? And trachea is completely centrally placed. There is no soft tissue abnormalities here, right? So that is why I technically say this is a normal chest X-ray. The pulmonary markings are indeed good enough. The heart size seems to be normal enough. Blood vessels do not seem to be expanded. So all these reasons include that I mentioned this X-ray as normal. But what happens in atelectasis is that there will be a shift. The shift will eventually be called as displacement. Okay. Remember, in colloquial terms, it is called as a shift, mediastinal shift, tracheal shift, you can call it as. But it is professionally speaking, it is called as displacement. So first sign, much more deeper, how do we actually say it as displacement of the interlobar fissures. Okay, there are two fissures, major fissure and the minor fissure, and that happens whenever there is an atelectasis. You have to remember that the displacement of the interlobar fissures toward the atelectasis area. Okay, wherever the area that has been atelectasis, that is the place where there will be a displacement of these interlobar fissures. Okay, major fissure and the minor fissure will be pulled up towards that the area of atelectasis. That's the first sign you have to remember. And at the same point of time, so I think yesterday somebody was asking me, sir, how could we actually recognize if there is only a single lobar atelectasis? Yes, this is the sign how I can recognize displacement of the interlobar fissure towards that area of atelectasis. We will see at the pictures, but first uh, try to understand the terms. Then there will be increase in the density of the affected lung. Like I was saying, yes, it will be opacified, it will look whiter, as because there is increase in the density. So increase in the density of the affected lung is the second sign. And third one is also all the mobile structures of the thorax. Mobile structures of the thorax is actually the trachea and the heart, right? All of and the diaphragm, let us say, okay, they will be shifted down towards the problem. Okay, wherever the opacity is present, they will be displaced to that side. So it is all about displacement of interlobar fissures and displacement of the thoracic sectors, and finally causing the density increase on that side. Okay, that is the simple basic approach of a atelectasis patient. Okay, so the mobile structures are those capable of movement during the changes in lung volume. So there will be a severe loss of volume, and that is one thing. Shift of the interlobar fissures, major fissure and the minor fissure towards the atelectasis, and then there will be displacement of the mobile structures of the thorax, which is the trachea, mediastinum, heart, and the diaphragm. And then at the same point of time, there will be increased density of the affected site. Okay, that are the three main important characteristic features of atelectasis, right? Look at here, look at this X-ray very carefully. Yesterday, I think last time we were talking about, okay, we were technically talking about the Silhouette sign. If you can remember the definition of the Silhouette sign, what actually I told you, if there is an obscuration of an anatomical structure, okay, if there is an obscuration of the edges of an anatomical structure, the pathology is present down in the anatomically related surrounding structure. What I actually meant to say is, okay, if there is a blurring of the edges between the two anatomical organs, there is blurring of edges between two anatomical organs, the problem is present. The problem is present in the anatomically related structure there. Here, what I actually meant by this thing is here, okay, this is the aortic knob I'm looking at. See how well and clear demarcated this one is. And I'm looking at the left heart border. You see here how well and clear demarcated it is. But look onto the right side, the right heart border is completely blurred. Okay, so which anatomical structure has got a blurring here? The heart, right heart border in particular, has got the blurring, right? So the problem is not present in that organ which has been blurred, but that the problem is present down in anatomically surrounding structure. So what is the structure that is anatomically present in this vicinity there? It is the right middle lobe. So any kind of a problem in the right middle lobe will cause a silhouetting of the right heart border, or there is a blurring of the right heart border. I can understand that there is a problem present in the right middle lobe. Did you understand this? So this one is actually called as the Silhouette sign. So I am using the knowledge of Silhouette sign to observe and make a diagnosis. Since the right heart border is blurred here, the problem is present down inside the middle lobe. Okay, right middle lobe. You see here, did you observe this? Yesterday, somebody was asking, sir, how would I actually recognize if there is a segmental atelectasis, if there is a lobar atelectasis? I think, is it that Martin or somebody? Benedict or Martin, I don't exactly remember. Is that clear now? This is how we use the Silhouette sign. We apply the Silhouette sign. We see which structure has been obscured, which structure borders are blurred, and then we will try to look at the related anatomical structures and say, conclude that their problem is present down in that structure, but not the one whose edge has been blurred. Okay, right? Yep. See, both of the pictures has atelectasis itself. Okay, look closely. The right heart border is obscured, the black arrow that is present here. Okay, the normal heart border has been silhouetted in the sense blurred out. Okay, and it has been blurred out, and at the same point of time there is an increased density along the same place. See, all the right heart border has been blurred along the black arrow, and there is an increased density along the white arrow. So which means to say the right heart border is being silhouetted by this density. Okay, so this density is the one that is causing the blurring of this border. And it means to say there is a middle lobe atelectasis. So this is what Silhouette sign, is it? Okay. No, no. Generally, you see here, when a small segment, okay, when a small segment or when a small part of a lobe has involved, generally you see here, like yesterday I was talking about the mass mass influence, and I'm also talking about the gravitational pull, and I'm also talking about the shrinkage and compression of all the bronchuses together, which will eventually cause what do you say, the uh, let us say I'm telling you that it is pulling down the trachea and it is also pulling down the heart. That does not technically happen unless a large region of the lung has been collapsed. Okay, that does not happen in lobar atelectasis and segmental atelectasis. Okay, that does not appear that way. Okay, so how do we actually recognize? Okay, yeah, how can I differentiate if this is a pneumonia or if it is some kind of a problem which is related to atelectasis? That should be a very good question. First, you have to understand, if you can look close enough here, I'm talking about every time you are looking at the celotes, right? You are looking at the celote. So what are the segments that are present down in the right middle lobe? What are the segments that are present down in the right middle lobe? Medial and lateral segments, right? Simple. It's very simple. We know, we applied the knowledge of anatomy here. Look closely, look closely. If this, what are the basic features of pneumonia? The basic features of pneumonia is nothing but your consolidation along with bronchogram sign, right? And there will be no volume loss in pneumonia. Yes or no? There is no volume loss in pneumonia. First thing, there will be an 8 bronchogram pattern, right? And there will be consolidation. That are the three signs of pneumonia. But if you look close enough here in this picture, or actually here is, you see here, the right middle lobe is actually divided down into two pulmonary segments, the medial segment and the lateral segment. So which means to say medial lobar bronchus and the medial lateral lobar bronchus are the one that supplies here. Apply the tactic of atelectasis. Whenever there is a problem of atelectasis, there will be the mobile structures and shifting of the major fissures or the minor fissures, right? So what is the fissure that will actually divide down the middle lobe and the lower lobe? What is the fissure that is present down between the middle lobe and the lower lobe? Oblique fissure, right? Right, major fissure or the oblique fissure. First, that one has to be pulled off. Okay, first that one has to be pulled off. And at the same time, the bronchus, that is what are the branches that are coming down from the bronchus intermedius? Yes, bronchus intermedius. From the bronchus intermedius itself, you will be getting the medial lobar bronchus and the lateral lobar bronchus, right? Segmental bronchuses, right? Medial segmental bronchus and the lateral segmental bronchuses of the right middle lobe. That is, and you see here, there is a sudden straightening of the bronchus intermedius. Look here closely, there is a sudden straightening, which means to say it has been pulled. This bronchus is being pulled. Did you get it? Did you understand closely here? This is the secondary sign that I'm looking at. This one, where the place has to be present down, you see here the pulmonary artery and the bronchus intermedius comes together. They, let us look at the normal x-ray and you can actually understand. You see here, can I see the bronchus intermedius here? See, this is the bronchus intermedius and this is the pulmonary artery. They come together. They are not suddenly, there is no such kind of a suddenly pulling up, straightening of the bronchus intermedius here in this normal x-ray. This is the pulmonary artery and this is the bronchus intermedius. If you look closely, there is no sudden pulling of that one. But in the other picture, right? But in the other picture, you see here, there is a sudden pulling. Pulmonary artery, it has been raised above the level of pulmonary artery. Did you see it? So this is the secondary sign. And you see here, this one is one of the thickening. You see here, there is a very thickened line here. There is a very thickened line here. So this is actually the major fissure that has been being pulled. Get it? Okay. Right? See? So you see here, this is the white dotted arrow that I'm looking at here. You see here, this is the white dotted arrow. On the lateral film itself, I found out that the white, see the dotted arrow, this is the minor fissure that is displaced downwards, and also the major fissure is displaced slightly upwards. Okay, it is difficult to observe, But you see here, this is the border I'm looking at. The second part of the the middle lobe and the lower lobes, where the major fissure and the minor fissure are the one that are deviating. Since there is a middle lobe and the minor fissure is the one that is dividing down the upper lobe and the middle lobe, so that is the reason I'm seeing the minor fissure around here. This is the upper lobar area and this is the middle lobar area. So my inner fissure has been downward, right? And you see here, there is the second part of the major fissure, which is actually dividing down the lower part of the middle lobe and the upper part of the lower lobe. So both of them are displaced upwards. So this is become more dense and that has come together, and that is the one that is causing the blurring of the right heart border. Is this clear? I think yes, the terms are a little bit confusing. If you are following the anatomical terms I have been talking about, it is quite easy to understand. Is it difficult or do you want me to repeat once again? Come on, guys, tell me. I know it is a little confusing, but still you just follow the anatomical structures. Okay, right. See here, let me take it slow, very, very slow. Okay. See, first things first, what we know about the first things, what do we actually observe? Let us do it step by step. First, what you have to look is that where is the opacity? Okay, the opacity is present around here. This is where the increased density. Now I have to differentiate if this is a pneumonia or if this is an atelectasis. So how do I say if it is a pneumonia or atelectasis? Pneumonia will have consolidation sign, blurred demarcation borders, right? And there will be no volume loss. There will be an air bronchogram pattern. Yes, that is what we know. Wait, Benedict, I will tell it because I'm repeating once again. Your answer will be, corrected there. Okay, it will be. This is not pneumonia. How can I actually understand it? Okay, first, what are the signs of pneumonia? There will be consolidation sign. The borders of the consolidation are blurry. There is no volume loss. There will be air bronchogram. First, in atelectasis, what is happening? There will be shift of the interlobar fissures. Minor fissure and major fissures will be shifted. The second sign is that there will be increased density of the affected area. Third, there will be displacement of the mobile structures. This is what I know of atelectasis. And how can I actually recognize between this? I will recognize it by applying the Silhouette sign. What is Silhouette sign? There is a blurring of the edges between two anatomical structures. If there is an blurring between the edges of two anatomical structures, the pathology is indeed present in the anatomically related structure to the edge whose blurring is there, right? So here, for example, there is a blurring of the right heart border, which means to say the problem is present in the anatomically related structure. So what is the one that is anatomically related? It's the middle lobe. Now, this is the first step we ever make. I came to observe that the problem is present in the right middle lobe. I still didn't know if it is pneumonia or if it is atelectasis. I just came to understand that this one is present down in the right middle lobe. Until here, is this clear for everyone? Yes. What are the steps I followed until now? Is this clear for everyone? Right? Benedict, is it clear until now? Right. Then what I do is that now I actually apply and try to differentiate between these things. First, if there is, now I came to understand that this density is indeed present in the right middle lobe. Now let us say if it is a pneumonia, look at the edges. Okay, is this edge sharp? Yes, this is sharp. Is this blurry? No, it is not blurry. You see here, this is sharp. Everywhere it is not, it is demarcated well, but it is not looking like pneumonia. Pneumonia will be completely hazy density, something like this. You see here, but this place is not pneumonia though. But actually, it will look so much blurred. Okay, but this is looking a lot sharper. Now that's what happens. Then I can think and tell. First, I have to look down is that if there is any kind of deviation in the mobile structures. So right middle lobe, what is the mobile structure that is present here? According to the movement of the right middle lobe, what are the structures that are going to move along with it? Pulmonary vessels and bronchuses, right? So what is the bronchus that is supplying? Okay, what is the bronchus that is supplying the right middle lobe? It is the seg segmental bronchus, medial segmental bronchus, or the lateral segmental bronchus. It's indeed. Who are these branches coming from? These branches are coming from the bronchus intermediates itself, right? So, which means to say, what is the dependent area of this right middle lobe? Bronchus intermedius. So, thus, mobile structure, the bronchus intermedius should be influenced. Now, that's the reason I see it here. Sorry. Bronchus intermedius is the structure that I have to observe. So this is the bronchus intermedius. You see here, the bronchus intermedius appears a lot stretched. If you can remember the normal X-ray, see, in the normal X-ray here, I can see the bronchus intermedius and pulmonary artery are together and they are not straight. But in the other picture, they became straight. You see here? Did you get it? And the bronchus intermedius pulled lower. So this is the pulmonary artery and the bronchus intermedius got a straight appearance. So this is why I understand that there is a pulling of the structure, displacement of the mobile structure, right? And at the same point of time, when I'm looking in the lateral X-ray, when I'm looking at the lateral X-ray, I'm always looking at the major fissure and the minor fissures on lateral X-rays. Okay, oblique fissure is technically not completely observed on an PA view, but it will be observed on the lateral view. If you can remember the fill in the blank I have given you last time with the lateral X-ray, I actually wanted you to recognize the what is the distribution of the major fissure and the minor fissure in that picture itself. So now, what is the role of major fissure and minor fissure in relation to the right middle lobe? Okay, that is the first question. So what is the relation? Right major fissure, sorry, right minor fissure divides down the lower part of the, okay, minor fissure divides the lower part of the right upper lobe and upper part of the right middle lobe. Point number one. Point number two, oblique fissure or the major fissure divides down the lower part of the right middle lobe and upper part of the right lower lobe. Point number two, both of them will be combined together because there is a collapse of the right middle lobe. So which means to say the right middle lobe is sandwiched between the fissures, which I'm looking on lateral side. Did you understand? Is this all these two signs are clear? One is tracheal pulling and other is that you see here the major lobar fissures and the minor fissures are being sandwiched together. So which one pulls down? Minor fissure is pulled downward. Okay, minor fissure is pulled downward and the major fissure is pulled upward. Okay, so now this is showing that there is a presence of collapsed lung in between them. Is this clear, Benedict? Now see, arrows are the one that are being pointed. Okay, so here, this one, see, this is the minor fissure and this is the major fissure. and this is an increased density. Okay, is that clear now? Benedict, did you understand now? What is being displaced upwards now? It is the major fissure that is being displaced upwards. It is the minor fissure that is displaced downwards. Hishman, Hisham, is it clear now? Can you see it? Yes, no, yes. So did your doubts get cleared? Is it clear for everyone? First, apply your silhouette sign. Then look for the opacity where that is present. Recognize the anatomical structure where the opacity is being present. Then look for the influential mobile structures. Influential mobile structures means to say trachea and the structures of the mediastinum. Third, then look for the displacement of the influenced tracheas. Okay, apply 3 steps and you will find out if there is presence of a lobar atelectasis or if it is a pneumonia. How can I differentiate it? Pneumonia has air bronchogram pattern, consolidation with blurred edges, right, with blurred borders, and there will be no volume loss. Atelectasis has volume loss, sharp, well demarcated borders, increased opacities than pneumonias. That is how I am going to differentiate between both of them. Is this clear now for all the people? Archana, Aman, Benedict, Martin, everybody, is this clear? Whoever did not understand, please tell me once again, okay? I know this is confusing. This is a lot confusing. This chapter is a little bit difficult, but still, it is easy if you know the anatomy, if you know about the tactics, okay? Clear? Hisham, it's clear? Is there any confusion? Benedict, is this clear? Respond. Did your doubt get cleared, Benedict? Right? Okay. So next one, what are we going to look at it? First things, we will go talk from every aspect. Trachea, okay? Trachea is generally present down in the midline. It is always centrally positioned. And how can I actually recognize the trachea? Trachea is recognized as a radiolucency, or means to say a black line or a black tube-like structure that is actually following down the spinous processes. Okay, the vertebral bodies, and it is non-rotated in a frontal X-ray. Okay, there is no deviation of the trachea. It is centrally positioned, and that centrally positioned X-ray will be centrally positioned trachea will always be present along the spinous process of some of the vertebral bodies, right? That is how it is. First things, okay, and there is always a slight rightward deviation of the trachea at the site of left-sided aortic knob. Remember, because of the presence of the ascending aorta and aortic knob, okay, ascending aorta and the presence of aortic knob, there is a little bit of slight deviation of the trachea towards the right, but it is almost present down within the, okay, almost present down within the spinous processes itself. You can almost see the spinous processes shadow between the trachea itself, but still there is a slight rightward deviation. You can't even pursue it. But with atelectasis, especially of the upper lobes, this trachea may be completely shifted down towards the volume loss. Now let us say if there is an atelectasis of the upper lobes, okay, atelectasis of the upper lobes will pull the trachea completely. What are the how many segmental bronchuses are present down in the upper lobe? People, how many segments are present down in the upper lobe, right upper lobe? Somebody is saying 2. Nitish, why 2? Shubham, why 2? Nitish, you are talking about the left. I'm talking about the right. The right has got, see, the right has got, I think just give me a minute. Just give me a minute. Apical, anterior, and posterior. So from which branch are they coming out? Okay, tell me extension of the bronchial tree there. Tell me the extension from the bronchial tree, how those branches are coming out. Continue with the bronchial tree. Right upper lobar bronchus. See, first trachea, then right main bronchus. The right main bronchus immediately pulls down as, sorry, immediately divides itself down as the right apical bronchus. Okay, then anterior bronchus and posterior bronchus. So 3 segmental bronchuses are coming down from the branches of right main bronchus. So let us say if there is a collapse of the right upper lobe, which are the structures that is being influenced here? These 3 segmental bronchuses, which eventually pull down the right main bronchus, yes or no? So there will be shifting, there will be pulling up of the right main bronchus, yes or no? If it is collapsed, there will be pulling of the right main bronchus, yes or no? If the right main bronchus is being pulled, what is its influence on the trachea? Will it be pulled again? Right? Exactly. So that is what happening in this picture. Look closely. There is a fan-shaped area that is an increased density here, right? Which, if you look close enough, okay, if you look close enough, you see here, this is the trachea, and you see here when it is coming down the inferior part, there is complete pulling of the trachea itself. This is became the right main upper lobar bronchus, right? So that is being completely pulled. So this, by this I can actually understand that this is the right upper lobar bronchus. And you see here, what happens here? What is the structure, anatomically mobile structure there? It is the right main bronchus, right? And the apical bronchus. Now, what is the other structures? What are the fissures that are related? Here, the minor fissure is the only one. So minor fissure is displaced upwards. So this white arrow I'm looking at is the minor fissure, right? See here, here. This is the minor fissure. So trachea is shifted to the right. This is the black arrow, which exactly I can say it is the right main bronchus I can talk. And then there will be displacement of the minor fissure upwards. So both of them are the signs of the right upper lobar atelectasis. Okay. Can everybody see the blackboard? Yes. Okay. You see here. Let us say these are the spinous processes that are looking as small, small dots. Okay. Trachea should be present like this. It is looking black, and only the edges of the trachea are the ones that are looking white. Okay. Now the trachea divides itself down into the right main bronchus and the left main bronchus. Okay. The right main bronchus and the left main bronchus. It divides down into three bronchuses here, called as the anterior bronchus, apical bronchus, and the posterior bronchus. Let us say if this segment or this lobe is collapsed, it is collapsing. So what actually this one completely gets shrinked, and it means to say this is pulling this one upwards and this one rightwards. And here at the same place here, this is the minor fissure. So this one will also be pulled inwards. Did you understand now this thing here? Benedict, is this clear now? Did you understand this? Yes? Please answer, everybody. I want you guys to take it very, very slow, okay? I will not rush up. Right? Now, let us talk about the middle lobe. This is the bronchus intermedius. The bronchus intermedius and the one that is actually dividing down into two segmental bronchuses, lateral bronchus and the medial bronchus, right? Now, let us say if this one is collapsed, right, this one will completely pull the trachea like this. This one will pull this bronchus completely. And then which one will pull? This is the minor fissure, right? Minor fissure is the one that divides the upper lobe and the middle lobe. Now, this one will go downwards. And this is the oblique fissure. Oblique fissure, there is the lower lobe like this here. Okay. So this one is also being pulled. Okay. The whole shrinkage is happening like this. So what happens? This minor in lower lobar fissure will go upwards. So which one is going upwards? The major fissure is going upwards. The minor fissure is being moved downwards, and the bronchus intermedius is being pulled straight. Did you understand this? Yes. Right? Yes, Benedict. Did you understand this now? Did you understand it, everybody? And that's the reason you see here. This also will eventually cause the blurring of this area, the complete blurring of this area, the right heart border. So this is actually called a silhouette because this one has completely shrinked. This area is completely shrinked, right? So that is what, how you apply the logic. See, whenever you are trying to look at the segmental or the lobar atelectasis, always try to imagine a diagram like this. Okay, unless you write it yourselves, you are going to get yourself so much confused. Get it? Practice well. Okay, right? So let's continue with it. I'm sorry, just wait a second. Okay, let me share up the other screen. So let's move forward in this one. So this is the upper lobar atelectasis, right? Upper lobar atelectasis. There will be the minor fissure displaced upwards and the trachea is shifted to the right. Okay, right? Trachea is shifted to the right. Next, you see here in the same way, the lateral lateral view also shows that there is a wedge-shaped density near the apex of the lung. The minor fissure, okay, what is the relation of the minor fissure here? The minor fissure is pulled upwards, okay, black arrow, this is the minor fissure that is pulled upwards, okay. Then, sorry, minor fissure is the white arrow that is pulled upwards, and the major fissure, the black arrow, is pulled forward, okay. So what does the major fissure do? Major fissure divides down the, see here, this is the major fissure, this is the major fissure here. Major fissure divides down the upper lobe. It is the first one fourth, right? First one fourth will actually divide down the upper lobe and the lower lobe. So that's the reason this one will be, you know, you hear, will be pulled forward. Major fissure will be pulled forward. Minor fissure will be pulled upward. Okay, right? Is it clear? Is this clear now? See, major fissure is the one that is actually dividing down the upper lobe and lower lobe also. So this one, major fissure, will be pulled forward, minor fissure will be pulled upward. That is how it is. So remember this diagram, and always try to utilize down and try to see what is the differences and what is its influence on the segmental bronchus. Okay, so it's that's how to keep working on. Okay, so this is a child who has an asthma leading to the formation of the mucus plugs actually obstructing the upper lobar bronchus. So what is the answer to your question last time? What if there is a foreign body, or if there is any kind of obstruction, what is the most common area to get obstruction? It is the right upper lobar bronchus, right? Because that is the one which eventually leads down to the lobar atelectasis. Got it? Right. Now, signs of atelectasis and its influence on the heart. The heart is at least 1 centimeter. The right heart border is at least 1 centimeter lateral that projects to the right of the spine, right? And a non-rotated frontal radiograph. Then, with atelectasis, especially of the lower lobes, the heart may shift down to one side or the other. When the heart shifts out towards the left, the right heart border will overlap with the spine. When the heart shifts towards the right, the left heart border will approach to the middle line. Okay. Now let me try to actually interpret this one for you. Okay. See here, this is the mediastinum, this is the heart. This is the heart. And it is present the right heart border. Let us say this is the spinous process like this. Okay. The 1 centimeter, the right heart border is 1 centimeter to the right to the midline. Yes or no? This is how it is here, right? If there is a problem, okay, if there is a problem when the heart shifts down, okay, the heart will be shifted down either onto this side or onto this side. Either it can be shifted like this, or it can be shifted like this. Either it can be shifted down onto the right, or either they can be shifted onto the left. Okay, if it is being shifted down to the left, okay, what happens if it is shifted down to the left? This right heart border will come like this. Yes or no? So the right heart border will overlap with the midline. If the heart is shifted to the right, what happens? The left part will be coming out like this. Did you understand? Is this concept clear now? Right? Yes? Is this concept clear? Right? Is this concept clear for everyone? Let me repeat once again. This is the spinous process, and the heart is like this. Okay, this is the spinous process, and the heart is like this. Then right part of the heart is present a little bit 1 centimeter to the right. Left heart is present a little more 3 or 4 centimeters to the left. If there is a shift of the heart to the right or to the left, if there is a shift of the heart to the right, what happens is that the left heart border will go in. So what happens? This is the left heart border, and the right heart border will be pulled more this way. So this is how the heart should look like. So the left heart border will move close to the midline. If the heart is being pulled down to the right side, what happens? The right heart border will be pulled down to away from the midline. So this is how it looks like here, right? So this will become the right heart border. This became the left heart border now. Again, right? So that is what it is. Generally, the heart should be present as normal here. So it is just about which side of the heart is being pulled, which side, okay? Right heart border being pulled or the left heart border being pulled. So that is also how I'm going to recognize my atelectasis as well, okay? Right? Can everybody see the screen here already? Can everybody see? Okay, right. Now, how are we going to recognize? You see here, in this X-ray, forget about the what it is that is written down there. First, you tell me somebody which heart border is shifted to which side. Can you see the right heart border here? The right heart border, yes, exactly. See, the right heart border is shifted down towards the left. Exactly. And that actually indicates that the heart has been shifted down towards the left, right? Exactly, right? The right heart border is present over the spinal shadow. So which means to say the heart has been shifted down towards the left. How can I actually understand that it has happened? You see here, the black dotted arrow is the nasogastric tube. See, this is the stomach. It is slowly entering down into the stomach. The nasogastric tube. Actually, it has to come down like this in straight, and at here, this level, it will actually go down into the stomach. But here, the nasogastric tube is completely displaced. It is actually being displaced because the heart is the one that is pushing the esophagus towards the left side, right? And also you look here, when you look close enough, when you look very, very close enough, there is a slight pushing of the trachea also to the left side. Now, can you tell me what is this problem? Which lobe of the lung is actually doing this kind of a problem? Jaffer, how can it be upper lobe? Lower or lingular? Lower or lingular? Is it lower or lingular? It is lower. Okay, see, the lower one will actually pull up this bronchus intermedius because there will be lingular segment along with the lower. Okay, the lingular segment along with lower superior parts of the lower. Okay, so this one has been atelectasis. So that's the reason there is a right shifting of the heart. Okay, right. Now, the right heart border, which should project about a centimeter to the left of the spine, has been pulled to the left side and there is no longer visible. The heart itself is not visible because it is no longer burdened by an air-filled lung. the patient has an obstruction of the bronchogenic carcinoma in the left main bronchus. So most part of the lungs, the whole part of the lung, okay, upper lobe was eventually collapsing, and the lower lobe was the one that is mainly influenced. So we can say that the left main lobar bronchus has been obstructed. Okay, generally you say here, unless there is a lingular segment. Why actually I have been telling about some part of the lingular segment and the lower lobe is because you see here the upper lobar bronchus actually does not have got a great influence, because it has got only two segmental bronchus, apico-posterior segmental bronchus and the anterior bronchus, right? So they did not eventually pull up the trachea very much, but it is the main influence of the lingular segment and the lower lobe which has got a lot of weight on this trachea, okay, on the left side, especially because of the reduction of the two segmental bronchuses. Right side has got 10 segmental bronchus and left side has got the 8 segmental bronchus. So this particular small reduction, you cannot completely appreciate the tracheal deviation here. Okay, so it is the right main bronchus eventually which has got the collapse of the lingular segment and the lower lobar segments first, and then the upper lobar segments are in after some time. Okay, right? So this is how I can actually recognize the mediastinal structure shift as well. Okay, then this is there is, you can see here, this is a complete opacification of the right hemithorax, where the trachea is shifted completely towards right. So right hemithorax is present here, right opacified hemithorax is present here. So the trachea is pulled down towards the right. The left heart border is displaced over to the right. So the left heart border became down into the central line and along the spinal shallow. So this is the right heart border. See, right? Now the left heart border is almost overlapping with the spine here, and the patient, actually what we can actually say here is that the patient has an endobronchial metastasis in the right main bronchus. See, the right main bronchus is completely abruptly stopped here. So the right main bronchus is completely stopped here. So endobronchial metastasis is there in the right main bronchus from the left-sided breast cancer. You can also see here the right breast shadow is well demarcated, but the left breast shadow is not present here in this patient. And you can also see that there is a lot of subcutaneous, tissue markings here. There are a lot of subcutaneous tissue markings, which actually indicates that they all are sutures. Okay, these are all sutures, suture lines. So the subcutaneous tissue itself shows that the left-sided mastectomy has indeed taken place, and the right breast shadow is visible. So this is a female patient, right? So it was actually happening because of the endobronchial metastasis that has happened, and is left breast is surgically absent. Okay, so is this concept clear here? The how does the heart structures move? How does the trachea move? Okay, is this clear now? Right? Okay. Hemidiaphragm. Hemidiaphragm is more and about the half interspace distance between the two adjacent ribs. Generally speaking, it is something around like 1.5 to 2 centimeters. Okay, the right hemidiaphragm is higher. Okay, this is the right hemidiaphragm and this is the left hemidiaphragm. So what is the distance between them? It is almost 1.5 to 2 centimeters. Okay, either this hemidiaphragm can be pulled down or can be pulled up. This can also be pulled down or can also be pulled up. Okay, now understand this logic. See, understand one simple logic here. Let us say if the right hemidiaphragm is pulled down, because of a problem down in the right lung. So the distance between the right hemidiaphragm and the left hemidiaphragm decreases. Yes or no? Yes or no? If there is a problem that is present down in the right lung, or if there is a problem present down in the left lung, let us say if you have observed in your x-ray that the right hemidiaphragm is lower, it means to say the distance between the right hemidiaphragm and the left hemidiaphragm decreases. Yes or no? If there is any kind of if the right hemidiaphragm is pushed up, which means to say the distance between the right hemidiaphragm and the left hemidiaphragm increases. Yes or no? Yes or no? Right? Right? So now you see here how we actually do it. How we actually apply this kind of knowledge here is that, okay, can everybody see the screen of the slides? Yes? See, in the presence of atelectasis, especially of the lower lobes, the hemidiaphragm on the affected site will be usually displaced upwards. Okay? Now, what I actually said apply here. If there is a problem on the right side, let us say this is the right side, this is the left side. If there is a problem on the right side, the affected site is right side, so the hemidiaphragm on that side will be displaced upwards, which means to say the distance between the right hemidiaphragm and the left hemidiaphragm increases. Yes or no? The distance between the right hemidiaphragm and the left hemidiaphragm increases. This is the place where the right hemidiaphragm should be, right? Okay, so that's what it is, right? So that is what actually happens. That is what we are going to look. Let's complete only this part here and then take a break, okay? So here, you see here, can everybody see the slides now? In this one, there is a shadow, okay? I think let's not look at the hemidiaphragm here. Okay, maybe let us stop here. Let's have a break. We will meet at 2:30. All right. Okay. There are other chapters. Okay. It is 2:15 now. Let's meet at 3:30. 15 minutes. All right. Okay. Can everybody hear me? Right. So let's try to continue. Okay. I will try to complete off fast for the next coming few slides, because now you have known the concept. It should not be very difficult for you to understand now. See here, if there is an left upper lobar atelectasis, what actually happens is that there is a density that is seen around here. You see here, there is a hazy density that is present in the left upper lobe, and then there is a soft tissue mass along the left hilum. Okay, this is the mass. Okay, now, which also shows that you see here on the same side, on the left side, where the left hemidiaphragm should be present lower than the right, it came down to the same level, right? You see here, the left hemidiaphragm came down to the same level. So the takeaway home point here is that what is the pathology that causes the diaphragms to be at the same level? Okay, there is a difference between the right hemidiaphragm and the left hemidiaphragm. Right hemidiaphragm is above and the left hemidiaphragm is below. The left hemidiaphragm is below because of the presence of the heart to expand. Okay, the presence of the heart and the systolic and diastolic movements of the heart is actually facilitated, that actually causes the left hemidiaphragm to be pulled downwards. Okay, it is not the liver that is influencing the heart. The evidence to this one will actually, we see it by from the what do you say, dextrocardia. Dextrocardia has demonstrated that even if the heart is present down on the right side, the right hemidiaphragm is shifted downwards. So by that, I can understand that it is the heart that is influencing the level of the diaphragm, but not the liver. Okay. But you see here in upper lobar atelectasis on the left, what actually I can see a hazy density, the white arrow, and I can see a mass in the left arrow region here in the left hilum. Both of them, eventually what they did is that it is the left hemidiaphragm that has been pulled up. So the hemidiaphragms coming down at the same level happens in case of left upper lobar atelectasis. Remember it as simple as that way. Now, if we see in the lateral, now we see it in the, in the lateral film, what actually the left hemidiaphragm shadow, okay, is pulled up to the same level, okay, right? Because of the left upper lobar atelectasis. This is the atelectasis, right? Okay, this is the right lung. Okay, this is the left upper lobar atelectasis that is present down here. So that's what we should see here, right? And you can also see here in the, it is a band-like density here. Okay, the lateral projection shows a band-like increased density, and it is the one that is actually representing the upper lobar atelectasis on the left upper lobar atelectasis. And the left upper lobe, sharply demarcated by the major fissure, also has been pulled anteriorly. So if you can understand the logic, what we have just interpreted before is the one. So here, what happens here is that the major fissure is actually pulled anteriorly. And also the same thing, the patient actually had a squamous cell carcinoma of the left upper lobar bronchus that was producing the complete obstruction of that bronchus. So the patient have had a squamous cell carcinoma. You can actually appreciate the atelectasis very much on a CT scan, but still it is always necessary as a basic undergraduate doctor that you have to, try to interpret the lobar atelectasis on the chest X-ray films itself. Okay. So here you have to understand that the leveling of the diaphragms at the same place. Okay, diaphragms, both the hemidiaphragms reach at the same place, in particularly in case of left upper lobar atelectasis. That is how you should remember this. Okay, right. Now, other signs of atelectasis actually indicates that there is one area that has been collapsed, which means to say the aeration tissue is completely gone in that lung. If there is atelectasis of any part of a lung, the aeration mechanism is completely lost, which means to say there will be an increased pressure on the other lung to compensate for the air loss. Okay, for the aeration, one lung has been affected. Let us say the left lung has been affected. Now, what happens is that the other lung, which means to say the right, has got an increased compensation. Okay, it has to compensate for the loss of that volume which has gone in the left lung. So it will take up more air. It will take up more air. The greater the volume loss, the more the chronic of its presence, and the more lung on the opposite side has to compensate for that atelectasis. So, and it will actually cause the projection of that lung over to the midline. Okay, so it will cause the contralateral shifting of the lung across the midline. Let us say if there is a problem, let's try to look at this radiograph and try to interpret. There is a problem of the left hemithorax. I can see here there is a complete opacification of the left hemithorax, and I can see that there is the left main bronchus also has been splayed. You see here there is an increase in the angle between the left hemithorax, left main bronchus and the right main bronchus, and this one became more straight. Okay, so now what actually happened is that there is also tracheal pulling onto the left here, ipsilateral tracheal pulling. And you can also see that this patient here is a patient of pneumonectomy. How can I actually know? You see here there is an increased gap between the uh, fifth and sixth, fourth to seventh rib. You see here there is a gap in between, so which means to say the fifth rib was completely surgically removed, right? Fourth, fifth is removed, sixth, so there is an increased distance between the fourth and sixth ribs here. So by this I actually came to understand that this is a patient of pneumonectomy, and the complete lung was removed off. So now what actually happens is that the other lung is going to compensate for this. So what actually happens is that this one will take up more air now. This one will take up more air, and the lucency, the blackness will be crossing over the midline. And you can see here the lateral border of the right lung here, the lateral border of the right lung, which will actually eventually push the trachea onto the other side also. See, overinflation of the unaffected lung will also try to push the trachea down towards the affected side, right? So the problem is present down on the left side. There is an ipsilateral tracheal pulling, one. And the other thing is that the left lung is, the right lung is compensating, and there is an increased lucency over the spine. The thing is that you can also see the lateral margins of this lung, which is also pushing the trachea onto the contralateral side. That is what I actually meant to say in this will here. Okay. You can see, I can know that this patient is a pneumonectomy because the rib was removed. The fifth rib was completely removed off. Okay, so that is how. And you see here, in the lateral radiograph, actually the right lung has herniated along the midline to attempt to fill up the left hemithorax. Okay, which has increased lucency behind the sternum. You see here, there is increased lucency. I'm sorry. There is increased lucency just behind the sternum. You see here on the lateral radiograph, there is increased blackness. There is increased blackness over these areas. You see here. So that one is actually indicating the increased lucency on a lateral radiograph indicates that this lung, unaffected lung, the right side has been overly compensating. And you can also see here that the right hemidiaphragm on the lateral projection is the only one that has been visible. The left hemidiaphragm is not visible. Why the left hemidiaphragm is not visible? Because you see here, it has been completely opacified. So only single diaphragm is visible. So a single diaphragmatic line will be shown in left-sided pneumonectomy patients. Single diaphragmatic shadow on a lateral projection will be shown in left-sided pneumonectomy patients. Or let us say absent diaphragmatic line, okay, will be happening in left-sided pneumonectomy patients. Or the other way I was saying, same level diaphragms happens in case of left upper lobar atelectasis. That is what we are talking about, right? So if there is a problem in the left upper lobar atelectasis, both the diaphragms come down at the same level. Or the complete absence of the left hemidiaphragmatic shadow will happen in case of left-sided pneumonectomy patients. That is how we remember it. Now, what are exactly the signs of atelectasis? Right, let us recall once back again. Displacement of the major fissure and the minor fissure. So remember the mechanism of there. And then increase the density of the atelectatic portion of the lung. That is the second major sign. Shift of the mobile structures in the thorax. That is the heart, the trachea, and the hemidiaphragms. The heart, either it will be shifted down to the right or either down it will be shifted down to the left. Okay. So it is a contralateral shifting depending on the atelectasis. Trachea, yes, again, it is a contralateral shifting. Ipsilateral shifting of the heart and ipsilateral shifting of the trachea. Hemidiaphragm, it is also the ipsilaterally, if the problem is present, that is the way the hemidiaphragm will be pulled up. If there is a problem that is present on the left side, there will be left-sided hemidiaphragm pulling up. If the problem is present on the right side, there is a right-sided hemidiaphragm that is pulled up, right? Then compensatory overinflation of the unaffected segments of the lung. If the problem is present down in the left lung, if the complete left lung is collapsed, right lung will be overinflation, and that one will actually cause up more radiolucency in the lateral radiographs behind the sternum. So that is what the most important signs of atelectasis. Okay, do not ever forget, this can be asked as a 4 marks question, right? Okay, now we will be trying to look at some other signs of atelectasis. We were actually talking about the lung as a whole before, or we are talking about the lobes as a single parts. But what actually happens if there is an atelectasis of only a single segment? For example, let us say if there is only the anterior segment of the right upper lobe is affected, how that one will cause, what are the signs if there is only a single segment of a single lobe? Okay, that how we are going to analyze that at signs of atelectasis. So subsegmental atelectasis is the one that actually shows up as a discoid or plate-like atelectasis. Okay, there are other types of atelectasis and they are discoid atelectasis. Discoid atelectasis means to say there is a subsegmental atelectasis. Okay, then there is other type of atelectasis that is actually called as compressive atelectasis, and there is round atelectasis and obstructive atelectasis. We'll try to observe what exactly is a subsegmental atelectasis, compressive atelectasis, round atelectasis, and obstructive atelectasis. Okay, so these are the types of atelectasis. You can have them as a 2 marks question, says that, okay, what are the types of atelectasis? Okay, so remember, let's start with the subsegmental atelectasis. Subsegmental atelectasis is also known as a discoid atelectasis or plate-like atelectasis. The name itself says that if the atelectasis is present, it will show up as an opacified hemithorax. First thing, let us say if there is a subsegmental atelectasis, what actually happens is that will be looked down as a opacified disc. It will be looking up a white disc. It will be looking at as a white plate, which actually suggests me that there is a subsegmental atelectasis. Okay, subsegmental atelectasis actually produces linear densities of varying thickness, usually parallel to the diaphragm. You see here, remember, this is one of the most characteristic feature, that the subsegmental atelectasis will show up the parallel to the diaphragm. The thickness or the density is parallel, the radio opacity is parallel to the diaphragm, and most commonly along the lung bases. It does not produce any kind of a sufficient amount of volume loss to cause the shift of the mobile structures. So there will be no further pulling of the trachea, only because it is a very only segmental bronchus has been involved. They do not have the capacity to pull off the complete trachea. So tracheal shifting or the shifting of the thoracic structures do not happen in subsegmental atelectasis. Remember, if there is a lobar atelectasis, yes, shifting of the diaphragm, shifting of the trachea, shifting of the heart will happen. But if there is a subsegmental atelectasis, there will be no shift of the mobile thoracic structures, because it is not causing any sufficient volume loss. Okay, right? So, and it actually occurs in patients who are actually splinting, that not take a deep breath, such as post-operative patients or patients with only pleuritic chest pain. See, only it is actually seen in those patients who actually do not try to attempt a complete breath. Okay, there is no adequate inspiration. They are afraid to take enough air inside because there is a chest pain. Okay, there is It is not dyspnea that is actually causing it. It is actually hyperventilation and trying to attempt to take only less breaths. There will be tachyapnea in these patients. Since there is pain, these patients will be having tachyapnea. And for every tachyapnea, you mean to say every respiratory cycle, they will attempt to take only small air, small amounts of air. So which means to say their total vital capacity is reduced. Okay, did you understand this concept here? How I am going to relate it to clinically? These patients will present up with pleuritic chest pain. If they have chest pain, because they are afraid to take the lung as the pain aggravates, so what they do, they attempt to take very short breaths, which eventually causes the tachyapnea. Tachyapnea means to say increased respiration cycles. Okay, subsegmental atelectasis is not due to bronchial obstruction. Okay, it is not due to bronchial obstruction, but it is related to the deactivation of the surfactants. Surfactant is a lubricative substance that actually provides the complete expansion or the complete relaxation, complete inflation and complete deflation of the lungs, which actually leads to the collapse of air spaces in non-segmental and non-lobar distribution. If the surfactant is less, which will eventually cause that particular segment to completely collapse, and the surfactant is the one that actually provides enough aeration, complete expansion of the lung, complete inflation of the lung is actually happening because of the surfactant is released by the type 2 pneumocytes, right? So in all the patients, for example, to say if there is a patient with cystic fibrosis where there is a deficiency of the surfactant or the protein B deficiency kind of patients, in those patients there will be complete deactivation of the surfactant, which eventually leads down to the segmental and lobar atelectasis, okay, which will cause the subsegmental atelectasis. Remember, what is the cause for subsegmental atelectasis? It is the deactivation of the surfactant. Okay, and these patients will cannot take up the complete air, so there will be tachyapnea in those patients. Now you see here, we can see here, you see here, this is very thin demarcated line. I can see a very thin demarcated line here along the right and left hard borders. Now this one actually is parallel to the diaphragm. You see here, these are parallel to the diaphragm. But you have to understand one thing here. How is these lines different from the Kerley B lines? Kerley B lines are actually happening in the periphery here, but this one is actually happening in the midline, across the midline, right? You see here. So this is the difference. It is not a Kerley B line. This one here, the Kerley B lines come down in the periphery here. Kerley B lines are the dilated pulmonary vessels, whereas subsegmental atelectasis is the major fissure or the minor fissure or whatever the fissures that are actually completely compressed down due to the atelectasis of that particular segment itself, right? Okay, each pulmonary segment has got its own interstitium along with it, right? So that's what it is. It actually causes the pulling of the fissures around that place, so which will actually look like a sub segment or a disc like or a plate like thing. So discoid atelectasis will show up as parallel lines to the diaphragms. Okay, and this is a very much characteristic feature of a fibrosis patient. Any kind of a patient has a pulmonary fibrosis, and the segments, depending on the extension of the pulmonary fibrosis or the region of the lung involved, they will show up as subsegmental atelectasis or discoid atelectasis, and they happen in the center. Okay, the Kerley B lines happen in the periphery, right? So this patient actually had a postoperative abdominal surgery and was unable to take a deep breath. So the atelectasis disappeared within few days after surgery. So these patient is generally only afraid to take off air because there is a lot of pain. So that one is actually causing a discoid or plate-like atelectasis. Is this concept clear now? Right? Please respond. Please respond. Is this concept clear? Right. Okay, let's continue the other one. Now you see here, next one is compressive atelectasis. Okay, you may not be really, remember every detail of what we are dealing in this chapter, but try to remember the terms. Okay, try to remember the terms. A lot of MCQs and a lot of fill in the blanks can be asked from this chapter. So the next one is compressive atelectasis. Compressive atelectasis is the loss of volume due to passive compression of the lung. Okay, passive compression of the lung that can be caused by a poor inspiratory effort, where there is a passive atelectasis of the lungs at the bases. Large pleural effusions, large pneumothoraces, or the space occupying lesions such as a large mass inside the lung will eventually cause you compressive atelectasis. Compressive atelectasis is nothing but like that there is a mass which will actually push up the area that is surrounding anatomically, right? The area will be pushed and there will be counteractive compression. So the counteractive compression is nothing but your passive compression, which will actually cause the patient to have a poor inspiratory effect. And the other thing is that there will be same signs that are seen as down in the pleural effusion and pneumothorax. So when caused by a pure inspiratory effort, passive atelectasis may mimic an airspace disease at the basis. So mimicking of airspace disease only at the basis is actually seen down as a characteristic feature of compressive atelectasis. You see here, in this patient, we can actually see that there is actually a poor inspiratory effort in this patient, okay, which will actually manifested as the increased density along the lower base of the lung. Okay, you cannot technically call it as a pneumonia of the lower lobe. Okay, it is not called as the pneumonia of the lower lobe. It is actually, why? Because the pneumonia of the lower lobe will be much more whiter than this. Okay, pneumonia of the lower lobe will be much more whiter than this, and there will be an 8 bronchogram pattern. But you see here, there is no such kind of thing. There is only a hazy density that is present down along this area. So this is the left hemidiaphragm, and this is where I'm seeing that there is a only hazy density. And you see here, when you look at this picture, okay, their whole ribs are not being visualized. The 10 posterior ribs are not being visualized, and the sixth and seventh posterior ribs are also not being visualized. So which means to say the patient did not take enough inspiration. So adequate inspiration is not there, and as a result, what happened? The smaller area of the lung became a hazy density. So by this, I came to understand that there is a compressive atelectasis, right? So that is how I came to find out why I am using the, why I am checking down for the quality, because I'm trying to think about a disease and I'm trying to differentiate it between the poor inspiration effort, or if it is a compressive atelectasis, or if it is happening because of some other problems inside the lung. Okay, so uh, what it can actually happen because of a secondary large pneumothorax or a pleural effusion. Okay, that is the main causes of the pleural effusion. Sorry, the main reason for this compressive atelectasis could be a counteractive pleural effusion or a pneumothorax, which means to say at the lateral border of the lungs that there is a pressure from here. So which means to say it will be completely compressing all the structures that are present down at the base. Okay, so that's what is causing the compressive atelectasis. Okay, look at this image in the CT scan here. Okay, the left lower lobe. Okay, this is the left lower lobe. Here, the black dotted arrow is the left lower lobe, and there is a homogeneous density that is present down on the base, on the posterior side. And like yesterday, I was talking that the pleural effusion will completely be present on the dependent areas. Since the patient is lying down in the supine position, I can see a homogeneous density that is present along the posterior sides of the lungs. Okay, and at the same time, this effusion, by this, it is a fluid density. So by this, I came to understand that this is a moderate level of pleural effusion. Okay, and you can see here it has just been divided down. So which means to say almost a complete lower lobe has been counteractively compressed by this pleural effusion. So this is a moderate level pleural effusion, and now which compresses the complete left lower lobe. So now this became atelectic. So this is a compressive atelectasis. Did you understand? This is not discoid atelectasis. Okay, discoid atelectasis is actually happening because of the compression. Okay, discoid atelectasis is actually happening because of the compression, which is actually because of the deactivation of the surfactant. But this one is not. It is actually happening only because of this one large pleural effusion is taking up the space of the lung, so that is the reason it is counteractively compressed. So how can I know this is a fluid density? I can know this is a fluid density because uh, it is showing up on the posterior sides, and since the patient is lying in supine position and fluid goes down and settles down in the dependent areas of the lungs, so that's the reason I came to understand that this density is not a mass, that this is a pleural effusion. Okay, and you see here they have got well demarcated uh, borders, and now you see here this lung has been completely collapsed and it became completely compressed. So is this concept clear now? Okay, what is the difference between a discoid atelectasis and a compressive atelectasis? Yes, please respond. Right, Benedict, right? Did you understand? Is everything clear for everybody? Okay, right. And you can also see here atelectasis and effusion is actually is an omnious combination. Omnious combination in the sense that they are working together. Okay, and you see here there is an opacification of the complete right. And you tell me one thing, if it is actually happens, uh, try to analyze this X-ray, and we see here there is a no shifting of the trachea in this picture. Okay, there is a slight rotation, I agree with that, but the trachea is not shifted, even though that there is a complete opacification on the right side. Unlike the other pictures we saw until now, there is no shifting or bending of the trachea, right? And you see here even the heart is present down at the mid clavicular line itself. Okay, this is the mid clavicular line. Okay, the apex of the heart is never shifted down over the mid-clavicular line itself. So which actually says that this patient is not showing up any shift of the mediastinal or the tracheal structures. And also on the opacification on the other side, there is no air bronchogram pattern. Okay, right? There is no air bronchogram pattern to suggest pneumonia. First thing, there is no shift of the trachea or the heart. So what actually happens is that both of them, so is this happening because of atelectasis or an effusion? Okay. Now, if the absence of any shift of the structures suggests the possibility of atelectasis and pleural effusion in balance. So which means to say there is equal amount of atelectasis to the equal amounts of the pleural effusion, which is causing contractive compression. So this combination actually should rise to a situation where the lung will be compressed. One, the most important cause of a lung compression is the obstruction to the bronchus. First most common cause is the mucoid obstruction, mucus obstructions, and the second one is the bronchogenic carcinoma. What also the disease causes massive pleural effusions? It is the bronchogenic carcinoma. Now you see here there is atelectasis one, there is also pleural effusion one. They are working together. And what is the most common condition that is actually causing both atelectasis and pleural effusion? It is the central bronchogenic carcinoma, central lung cancer, we call it as. Okay, so that one is actually causing obstructive atelectasis and also the metastasis, which is actually causing large pleural effusion. And now they are working in combination. So that's the reason, even if there is pulling of the trachea or pushing of the trachea, one is actually, if there is a pleural effusion, that will push the trachea other side, and the atelectasis is there, that will again pull the trachea towards its side. So that's the reason there is no shifting of the trachea or the mediastinal structures happened. Did you understand it? It is balanced. The pushing by the pleural effusion to the other side, the pulling of the trachea to the same side is compensated because the force is equal. So that's the reason the trachea and the mediastinal structures are indeed present down in the midline itself. Did you understand? So central bronchogenic carcinoma will not cause any tracheal shift or mediastinal shift. It is actually happening because of two conditions. One is obstructive atelectasis is counteractively preventing the large pleural effusion force. Is this concept clear? Right? Did you understand here? So what is the condition that will not cause any kind of will not cause any kind of tracheal shifting or hemidiaphragmatic shadows or anything? It is actually the bronchogenic carcinoma. Okay. Did you appreciate this in the image? Okay, go back and once again do it. Okay, you can easily find it. Next type of atelectasis is the round atelectasis. The round atelectasis is actually a form of compressive atelectasis that is seen usually in the peripheries of the lung bases. Okay, before we were seeing at the subsegmental atelectasis that is actually happening in the midline, but now this round atelectasis is actually happening in the periphery of the lung base and develops from a combination of prior pleural disease, okay, prior pleural disease, and then the formation of the pleural effusion that produces adjacent compressive atelectasis. Okay, there is a combination of a prior pleural disease, for example, to say like the cystic fibrosis or the honeycombing appearance or the pulmonary fibrosis, interstitial lung disease, presence of any kind of interstitial lung disease, and that one will actually cause the pleural effusions as well. So both of them, which will cause the compressive atelectasis and also because of the interstitium. See, first one is the collapse of the interstitium. So it is a combination of subsegmental atelectasis and compressive atelectasis that is happening together. So that is actually causes the round atelectasis. So when the pleural effusion is completely taken off, recedes, the underlying pleural disease leads to the portion of the atelectic lung to become trapped. So this produces a mass-like lesion that can be confused for a tumor. On computed tomography, a CT scan of a chest, the bronchovascular markings are characteristically lead to form a round atelectasis that is back to the hilum, producing a comet tail appearance. Okay, remember last time, yesterday, we were talking about the pleural tail sign that is entirely different from this, and this is actually the comet tail appearance. Okay, so comet tail appearance is a characteristic feature of what? Rounded atelectasis. Okay. Pleural tail sign is a characteristic feature of a mass, which is having a completely relations to the, the surrounding pleural structures, that is pleural tail sign. But this is actually a comet tail sign, which is actually has a bronchovascular markings, but a mass do not have a bronchovascular markings. Okay, that is the only difference here. Now we can see here, you can see this is a mass, there is a mass that is present here. Okay, dotted black arrow, this one is the mass that is present down in the left posterior, left lower lobe. Okay, upper part of the lower lobe. Okay, this is the superior segment, dorsal segment, you can say. There is a mass present in the left dorsal segment of the left lower lobe. Okay, and the patient has underlying pleural disease, and where you see here there is a lot of increased density along the pleural surfaces here, so which is actually called as pleural flaking. Increased density along the pleural surfaces is called as pleural flaking, and that one is actually happening. It's a characteristic feature of asbestosis. Okay, pleural flaking is a characteristic feature of asbestosis. You can also remember that geographic lung. Okay, there is a thing that is called as geographic lung. Okay, geographic lung or geographic plaques are seen in asbestosis. Okay, geographic lung or geographic plaques are seen in asbestosis. So these are the densities that are actually showing up here, right? So that one and this one is actually causing a round atelectasis. So this is actually the left lower lobe, that is the one that is actually causing a round atelectasis. So the dorsal segment of the left lower lobe is the one that is completely compressed because of the connections down related to this pleural plex. Okay, that is the uh, evidence here. Okay, there is a comet tail shape in the bronchovascular markings that emanate from the mass and extend back to the hilum. Okay, you see here, this one is directly related down to the hilum. Okay, this one, and you can also see that there are bronchovascular markings. But if this could have been a mass, I cannot see the bronchovascular markings in that lobe itself. Okay, in that segment or in that lobe, I won't be seeing. If this is a mass, this won't be happening down here. But since it is not a mass, it is just only a compressed lung. So that's the reason I was able to see the bronchovascular markings. So this combination of findings is a characteristic feature of round atelectasis, and it should not be mistaken for a tumor, right? The next type of atelectasis is obstructive atelectasis, and it is actually happening because of the resorption of the air from the alveoli, thrombic pulmonary capillary blood, and distal to the obstructing the lesion of the bronchial tree. Okay, resorption of the air from the alveoli and distal to the obstructing lesion of the bronchial tree. And what actually happens is that they should be resolving within 18 to 24 hours, and collapse will take place. Okay, and if supplied with oxygen, they will be resolving within an hour, but it takes to develop something around like 18 to 24 hours of the entire collapse. Okay, so what is the main reason for obstructive atelectasis? It is the resorption of the alveoli and distal to an obstructing lesion. Let's it is a little difficult unless we look in the picture. You actually do not understand what is the definition of this one. But first try to complete off this one here. Okay, the affected segment of the lobe or the lung collapses will become more opaque, as simple as that, because it contains no air. Then the collapse leads to the volume loss. Yes, that we also know for a fact till now. Affected segment will be there will be no air, that will become more white, opaque, and then the collapse actually leads to the volume loss also, because then there is the visceral and the parietal pleura invariably remain in contact with each other. As the losses of the lung volume, there is a pull on the mobile structures of the thorax towards the area of atelectasis. That is also what we have seen before. There will be pulling of the mobile structures, and this one is actually called as obstructive atelectasis. So all the features that what we have seen before is the characteristic features of obstructive atelectasis. There will be the same thing. The first main, as either it can be in a segment or either it can be in a lobe. First one, when we are trying to learn about the atelectasis, I told you the lung as a whole. Okay, there is the left main bronchus that has been completely obstructed, will cause the complete opacification, and there will be ipsilateral tracheal pulling, ipsilateral ipsilateral tracheal pulling, and ipsilateral mediastinal structure pulling, and diaphragmatic pulling. And that is actually happening in a single segment or in a single lobe now. That is the only difference. Obstructive atelectasis will happen in the one, whatever the bronchus that has been obstructed, and that will eventually cause on the mobile structures to move towards the area of atelectasis. We have already seen and understood this problem, right? So it is, there is nothing much to understand here. It is very, not really very difficult, right? So now let us look at some patterns of the lobar atelectasis. Okay, this is not very difficult. We came to understand that before. We see that the fan shaped triangle anchored at the pleural surface, and the apex of the triangle is anchored towards the hilum. Okay, remember what is the characteristic, what is the pattern here? Okay, the pattern is, if there is a lobar collapse, okay, if there is a lobar collapse, it will cause the base of the fan. Okay, if there is a triangle, okay, if there is a triangle, the base of the triangle is anchored to the pleural surface, and the apex is towards the hilum. That is what you have to remember in this pattern. Okay, that's it. The base is towards the pleural surface, the apex is towards the hilum. Any kind of a structure will be pulled towards the hilum. That is what our overall takeover home message is. Okay, the base is along the pleura, which is actually causing the discoid shape like atelectasis, right? And the other one is the apex of the triangle, which will be the ipsilateral pulling of the trachea towards the apex, towards the hilum. That is what actually happening. We have been observing the same effect from before. So apex will be towards the hilum, and the discoid shape or the fan shaped will be base will be showing down along the pleural surface. Is this clear now? Is this concept clear? This is the simple take-home message of all the atelectasis. Where is the base and where is the apex? Apex is towards the hilum and base is towards the pleural surface of the affected area, right? And other unaffected lobes will undergo compensatory hyperinflation. Do not ever forget this compensatory mechanism. Whenever a part of the lung has been affected, there will be hyperinflation because the other parts will try to compensate for this aeration. Okay, right? And the right upper lobar atelectasis, we saw it. What actually we saw? Let us, this is just an overall view, whatever we have learned until now. Okay, on the frontal radiograph, if there is an upper lobe atelectasis, there is upward shift of the minor fissure, there is a rightward shift of the trachea. Simple. Okay, right upper lobe atelectasis, there is a rightward shift, ipsilateral tracheal shift, and superior lifting or the upper lifting of the minor fissure. Later radiograph, there is an upward shift of the minor fissure and the forward shift of the major fissure. Okay, if there is an enough mass in the right hilum, the hilar mass and the upward shift of the minor fissure produces a characteristic appearance, which is actually called as the golden sign of S. Remember, this is the first sign that we are going to learn. It is a very, very characteristic feature. Do not ever forget, there is a mass. Okay, you will understand if it is in the picture. See here in this picture, this one, there is a mass. Okay, this one, there is a mass. There is an atelectasis. Okay, which is actually indicating that there is a shifting of the minor fissure. One, and this is the border of the mass, soft tissue mass. Both of them will look like an S. So this one is called as the golden sign of S. Golden sign of S is a characteristic feature of what this is? It is a characteristic feature. An X-ray like this. Can you see the can you see the image? Yes, no? Okay, just wait, just wait. I think yes, I can. There is a little problem. Just wait. Okay, let me share once again. Yeah. Yeah, can you see now? Can you see now? Yes. Can you see now? Right. Okay. What I'm talking about here, if there is a mass, first counteractive compressive atelectasis has to happen. So that's the reason there will be ipsilateral tracheal pulling. You see here, this trachea is a little bent. So there is an ipsilateral tracheal shift. And along the same way that the minor fissure will be moved upward. So this one you see here, there's the minor fissure that has been moved upward. And along the same place, there is a mass that is also pulling downward. Okay. So that's the reason you see here, the trachea appears to be kinked. It is looking crooked, right? So if it is looking crooked, this is the one, and there is an S shape here, there is an S shape here. So this is actually called as, you cannot hear, everybody can hear or cannot hear? Can you guys hear me? Can hear, okay, right. So this is actually called as the golden sign of S. You also have to remember the other name for this is the transverse S sign. Okay, transverse S sign, transverse S sign, or golden sign of S. Okay, remember, it actually indicates that the patient is suffering from central bronchogenic carcinoma. Okay, central bronchogenic carcinoma. It is the simplest definition is present down inside the practical slides, but remember, right upper lobar atelectasis along with a hilar mass will give down to the golden sign of S. It is actually happening because of upper lobar bronchogenic carcinoma. Okay, golden sign of S is present or seen in upper lobes. Okay, that's it. So this patient is suffering from a squamous cell carcinoma, okay, in the upper lobar bronchus. Okay, and I can also see that there is a central line placement here. This is the brachiocephalic vein that is coming down. The central line is entering down into the superior vena cava of the heart. So this line, what this opacity, what you are looking at, is the central line. Okay, right. That's, you see here, this is the minor fissure, shifting up of the minor fissure along with the mass. So this is the golden sign of S, which is a characteristic feature of upper lobar atelectasis along with a hilar mass. Okay, left upper lobar atelectasis, we will be seeing there is a hazy area around the density in the surrounding left hilum. There is a leftward ipsilateral tracheal shift, and there will be elevation or a tenting with the peaking of the left hemidiaphragm. Left hemidiaphragm will be pulled up if there is a problem that is present down in the left upper lobe or atelectasis. Compensatory overinflation, okay? Compensatory overinflation of the lower lobe may cause the superior segment of the left upper lobe to extend to the apex of the lung on the thoracic on the effect side, okay? So compensation overflow will actually cause the superior segment of the left lower lobe go to the apex, okay? That is the characteristic feature. On lateral radiograph, there is a forward displacement of the major fissure and opacified upper lobes or the band of increased density running roughly parallel to the sternum, okay? So this is what radiolucency that is present before the sternum, that is what we are talking about. Radiolucency before the sternum is actually causing by the left upper lobar atelectasis. Okay, lower lobe atelectasis, this is just a summary of what we have learned until now. Okay, that is what we are just doing it. So if you are asked to write about the characteristic radiographic features, you try to get your answers from this place. Okay, all the images are the ones that are necessary for the explanation, but if you are writing down as a single paragraph, yes, you are trying to use this one. Lower lobar atelectasis, right and lower left lobes collapse leads to form down a triangular density that extends from its apex at the hilum to the base at the medial portion of the affected hemidiaphragm. There will be elevation of the hemidiaphragm on the affected side. Heart may shift towards the side of volume loss. There is a downward shift of the major fissure. So these are the three characteristic features that are coming down together. Okay, so first this will be the base that is present down, and the pleural base is present, and the apex is towards the hilum. That is the first sign. Then there is an elevation of the hemidiaphragm, that is we also know as per a fact. There will be mediastinal shift, that is also we also know until we have learned till now. And then there will be a downward shift of the major fissure, that is also we have already seen the mechanism. So lower lobar atelectasis will have a compensatory features like this, right? On the lateral radiograph, but you see here, there is no compensation by the other lobes of the lungs. Generally, it is does not happen because the larger volume is present down in the lower lobes itself. So the middle lobe and the upper lobes generally will not be able to compensate to the largest volume that has been collapsed. Okay, they cannot compensate it. So lower lobar atelectasis generally do not have hyperinflated lungs. If the upper lobes are collapsed, yes, lower lobes will try to compensate it. But if lower lobes are collapsed, the upper lobes cannot be able to compensate it, because they have this smaller space, smaller area. Okay, both downward and posterior displacement of the major fissure until completely collapsed lower lobe forms a small triangular density at the posterior costophrenic angle. So you see here, right? A fan-shaped area. This is what the fan-shaped area. Displaced major fissure. Okay, medially displaced major fissure. And you see here this the fan-shaped area that is actually, and the apex is towards the hilum. Okay, right? And you see here in the lateral radiograph, I can see here this is the base pleural surface, and the apex is towards the hilum. Okay, that is what the left lower lobar atelectasis shows up like. Okay, right. Next, right lower lobar atelectasis, you see here, that's the same thing, right? Superiorly made the major fissure, and the silhouetting the hemidiaphragmatic shadow. Right hemidiaphragmatic shadow is not shown, and then there is a silhouetting here by the and shifting of the major fissure, right? So this one is the fan leg density. So that is actually telling me that this is a right lower lobar atelectasis. I cannot say this is a pneumonia, and it is not present in the middle lobe, because you see here I can still clearly see the right heart border. So silhouette sign is negative here. Silhouette sign is positive if it is happening down in the right middle lobe. And since I can see the right heart border, so that's the reason I came to understand that this is not the right middle lobe, but this is indeed the left lower lobe. Okay, now did you understand? It is clear now. How can I differentiate it between the left lower lobe and the middle lobes? I am applying just as the silhouette sign. Okay, clear now? Yes, no, please tell me. Right. And you see here, middle lobar atelectasis that we actually see here, there will be silhouetting on the base of the right heart border, and the apex is pointing towards the lateral chest wall. Minor fissure is displaced downwards. This is overall summary, okay, or what we until now what we are actually trying to do. Okay, I think I will skip off these parts. Okay, not necessary. Remember, any kind of an atelectasis will try to resolve within hours or last from many days once the obstruction has been removed. So slow resolving of the lobar or a whole lung atelectasis may manifest as patchy areas of the airspace disease surrounding by the progressively increased zones of the aerated lung until the atelectasis is completely cleared. It will take time from hours to many days depending on the amount of obstruction, okay, and depending on the amount of aeration. So it will take time. So you can see progressive atelectasis. Atelectasis is a progressive disease. Resolving is also progressive, obstruction is also progressive. Okay, now finally the whole thing what you have to remember the causes: tumors, bronchogenic carcinoma, especially squamous cell carcinoma, endobronchial metastasis, and carcinoid tumors will cause atelectasis. Then mucus plugs will cause atelectasis seen in asthma patient or cystic fibrosis. Foreign body aspiration, especially peanuts, toys, are the traumatic intubation. Yes, they will cause atelectasis. Inflammation, as in scarring, as of tuberculosis, cystic fibrosis, right? Or interstitial lung diseases. All of them will cause obstructive atelectasis. Remember, the whole things is that you have to remember one thing: the application of the silhouette sign in this chapter. One is application of the silhouette sign. The next one is the application of the which side the tracheal deviation or the tracheal shifting happening, which side the diaphragm is shifting, which side the heart is shifting. That is the thing, overall things. Okay, if you are asked about to describe the radiographic features of atelectasis, just describe these things is more than enough. The MCQs will be asked from, okay, right upper lobe will have which characteristic feature, left upper lobe will have characteristic features. That is the one for the MCQ purpose. Okay, practice this chapter very well. They can be, you will have a 4 marks question or a 2 marks question and many MCQs from this chapter. Okay, it is not difficult. I think it should be clear by now. Is everything clear? I know it is confusing. It is not difficult, I guess now. Yes. Did you guys all understand this chapter very well now? Yes or no? Yes. Benedict, were your doubts all clear? Brenda, Novella, Clara, all those guys? Did you understand it? Please respond. Please respond. Clear? Is it clear for all those guys? Give it a 2-time reading. Take it slow. Observe, try to observe each and every slide slowly and slowly. You will try to understand and you will remember them. Please do not neglect this chapter. Respiratory system will have so many questions. It is the most difficult of all radiology. Next one, central nervous system, is also same confusing like this. The easiest are the skeletal radiology and abdominal radiology. They are the most easiest, but most difficult are the respiratory system, cardiovascular system, and central nervous system. So we will take a lot of time for these things. For the coming 1 month, we are just doing only central nervous system and respiratory cardiovascular system. Okay, until next coming 2 weeks, because we still have so many chapters and so many diseases that is related to respiratory system. You see, skeletal system and other things, we will complete it off very fast. It is not really very difficult to read them. Okay, now let's complete off another one small chapter. It is quite easy. It is not difficult at all. Okay, it is never difficult. It is very easy to understand. Let's complete off that chapter first. It does not take a long time. Take around like 10 slides. That's it. We have already have a good base now. We already completed the logic of this chapter. Okay, so can let me see, where is it? Okay, okay, can everybody see the screen now? Can everybody see? Right. Okay. First, we are going to look around the recognizing a pneumothorax and a subcutaneous emphysema. Okay, what are the characteristic features? Like yesterday, I was telling, pneumothorax is filling up of air in the pleural cavity, filling up of air in the pleural cavity, and it is actually happening between the visceral and parietal layers. Okay, so how do I actually recognize a pneumothorax? Okay, remember, this chapter can be asked, okay, characteristic radiographic features of a pneumothorax can be asked as a 4 marks question. Okay, right? Atelectasis, yes, 2 marks, and complete 4 marks. Yes, pneumothorax also 4 marks, right? Okay. Pneumothorax occurs when air enters down into the pleural space. Okay, there's one will actually bring up the negative pressure and normally present down in this pleural space, rises higher than the interalveolar pressure, and the lung collapses. Yes, here also a lung collapse is there. You see here, right now you try to understand what exactly is the difference between a pneumothorax and an atelectasis. In atelectasis, the problem is present inside the lung. Yes or no? The problem is present inside the lung because of the obstruction or the mass or something, right? So this one, pneumothorax, the problem is not present inside the lung. The lung is completely healthy, but the problem is present because of the increased pushing of the air inside the pleural cavity. And as a result, the lung is collapsing. So it is a compressive atelectasis also that is happening here, right? So you will also find out the same. Negative pressure is that you see here, the air is able to enter down with into the lungs because there is an atmospheric pressure and difference between your interthoracic pressure, right? Okay, you understand? The air is entering inside the lungs because of the intrathoracic pressure. Okay, so that is what the negative pressure is it. And negative pressure in the sense it is completely whole as a vacuum. Okay, but let us say if this one is actually completely gone, this pressure is completely gone, so what actually this one will try to absorb the air that is completely present down inside the lungs, and the air will escape into the pleural cavity. Did you understand this? Okay, that is what the pressure difference. Okay, the pressure difference that exists between the lungs and the pleural cavity. That's it. Okay, so let us say if the pressure in the pleural cavity has increased, Eventually, what happens? It will flow from the high pressure region to the low pressure region, right? So what happens? The air will escape all from the low area from the lung into the pleural cavity itself. So that is what actually causing the pneumothorax. Okay. You do not understand about the, you need not technically remain about the, the pathophysiological mechanism here, because the radiographic features are quite easy to remember. So as a result, what actually happens, the now the lung has collapsed, so it actually becomes completely close together and they appear as a thin white line. Remember, the visceral pleura becomes a thin white line, and there is an air that is present between the parietal pleura. So visceral pleura is quite close to the lungs, so that one will become visible as a thin white line. That is the first radiographic feature you have to remember. So which is actually called as the visceral pleural white line, or simply called as the visceral pleural line. Okay, right? You see here, there is an air, in the pleural cavity. Air looks black, and this is the area. So that's the reason you see here, compared to this area here, compared to this area of the posterior ribs, and compared to this area of the posterior ribs, which one are more clear? Is it on the medial side or the lateral side? Okay, tell me. Compared to the rib shadows, which one are more clear? There is a lot of noise that is present along the posterior edges here, but here on the lateral side, and these clear rib shadows are appearing just because there is a lot of air that is present in the pleural cavity. And how can I also confirm with it? I can confirm that the all the visceral pleural line, there is a well thin, well demarcated pleural line that is coming down here. So by this, there are two radiographic features which are very, very important in recognizing a pneumothorax. How can I recognize? First is the visceral pleural white line along with the clear rib shadows. That is the radiographic feature of pneumothorax. We already completed the chapter. That is what we are observing here. Simple. Remember, the visceral pleural line indicates pneumothorax, and the clear rib shadows also indicates pneumothorax. Okay. Then generally, when the air is entering into the thoracic cavity here in the pleural cavity, the lung is pushed towards which side? Lung is pushed to medially or laterally? Lung is pushed medially or laterally? Medially. So there will be lung retraction towards the hilum, the third radiographic feature. So the first radiographic feature is the visible pleural line. The second one is the clear rib shadows. The third feature is the lung is retracting towards the hilum. These are the three characteristic features of a pneumothorax. Okay, right? So that is what the visceral pleural line is, always convex outwards and towards the chest wall. And in absence of pulmonary markings, okay, other indirect feature what we can actually say is that, you see here, when we look close down to this picture, okay, when we look very closely, sorry, when I look closely in this picture, you see here, this area has got pulmonary vascular markings. But do you think here this area has got any pulmonary vascular markings? There are no vascular markings in the place where the clear rib shadows are present. Yes, see here there is pulmonary vascular markings, but here there are no pulmonary vascular markings. So the fourth radiographic feature, is that there are no pulmonary vascular markings. Okay, that is what. Can everybody appreciate this one? So there will be no pulmonary vascular markings, right? So we have got four radiographic features. One, there is a visceral pleural white line. Second, rib shadows are quite clear. Lung is retracted towards the hilum. Absence of pulmonary vascular markings over the areas of clear rib shadows. That is what it is, pneumothorax, right? So, and on a CT scan, you can appreciate it much more clearly. Compare it to the right side. You see here, there are a lot of pulmonary vascular markings that are present here. And you see here, I can see this as the visceral pleural line, one. And there is a complete homogeneous equal blackness. You see here in this area. So which will indicate that this is pure air, which is looking like the complete borders of the outside of the CT scan. Pure air is present here. You see here, that's the reason. Without any vascular markings are not even present. And I can see a very, very thin line here. And all the lung has been compressed. Now, you also see here that did this one actually push up the mediastinal structure? It did not technically push up the mediastinal structure. And it's the same way like the compensatory, it's the same way how the compressive atelectasis of the bronchogenic carcinoma is working in combination along with the pleural effusion. This one is also working the same way, depending on the percentage of the air or depending on the number of pulmonary segments that has been collapsed. Pneumothorax will either cause a contralateral shift or not. Okay, let us say only a single lobe of a lung has been collapsed, and single part only thorax, pneumothorax has been extending down only into a smaller part of the area, only in the lower areas. So the compensation will also not be very influenced. So that's the reason we pneumothorax. But remember one thing, pneumothoraxes will develop very, very fast, and the lung will collapse very, very fast. And unlike the pleural effusion, which takes so many days to months, pneumothorax will not develop like that. Pneumothorax will develop within days itself. We'll have something around like 3 or 4 days, it will be much more higher. So you can also see here in this patient, there is, okay, what is the muscle here? Okay, this is the subcutaneous area. Okay, serratus anterior. This is the around the place of serratus anterior and teres major and teres minor, right? So these areas also you see here along outside the thoracic cavity, there is also some air. So which means to say it is called a subcutaneous emphysema. Okay, remember, if there is an escape of air under the subcutaneous tissues, under the muscles, under the fascia, or under the skin, if there is air present that below the skin or muscles or the interfacial fascia, it is actually called as the subcutaneous emphysema. So this is another radiographic feature of a pneumothorax. Subcutaneous emphysema is present down in the soft tissues, air present in the soft tissues, and this one actually happens because of a penetrating trauma. Penetrating trauma is that, okay, if I stab somebody with a sharp object, it is called as penetrating trauma. So that one will eventually cause the air to escape from the external environment inside to the thoracic cavity. There is a communication. And now what actually happens is that this one will eventually start acting as a, okay, this one will start acting as a valve-like mechanism, and this does not allow the air to escape from the pleural cavity again through the external environment. This one does not happen. So air becomes trapped inside the pleural cavity because there is a stabbing wound. Okay, right? It's the same way. I think you have known the magic trick. What you have known about the magic trick where the people will hold some water inside a water bag and pierce the pencils through it, and the air does not escape or the water does not flow out, right? Have you seen this magic trick? Do you remember? I think if you have frequently been browsing on the YouTube, right, there are some kids actually doing this kind of a magic trick. Let us take a water inside a water bag, and then you see here, if you are piercing the pencils through it, the water does not come out. Okay, try to find out this magic trick. If you have seen, is there any person who has accidentally seen this magic trick? Yes, no? No? Okay, okay, okay. You have done it, Arslan. You have done it. I think maybe if you have found it in YouTube, maybe you can see it. See, it is just something. You take a water. Okay, you take water in a polythene bag. Okay, a lot of water in a polythene bag, and now try to pierce the pencil from one side to the other side completely, and finally the water does not flow out. Okay, you can also do the same kind of experiment within the, with a balloon also. Okay, let me find that experiment. If you let me see. Or yeah, yeah, the same thing, balloon and a needle one also, the same thing. Balloon along with needle, balloon that is filled up with water, right? Yeah, with oil on the needle. Yeah, exactly, that one. Yes, true. That it does not escape, right? Air, and that the balloon does not collapse, right, Aman? I think most of the people, yes, they most of the people that actually have seen this experiment. That's the reason. That is the same thing happening here in pneumothorax also. So the air gets entrapped inside. Okay, the air gets entrapped inside the pleural cavity. Okay, you find it in YouTube. It is always there in YouTube. It is a very famous magic trick. Okay, so now how can I recognize it? Visualization of the visceral pleural sign is the first most important radiographic feature. Next, convex surface of the visceral pleural line that is paralleling towards the chest wall. Second, and absence lung markings on the distal to the visceral pleural line, and the presence of air fluid interface in the pleural space. Okay, so that one are the four recognizing features of the pneumothorax. Do not ever forget, this is a very important radiographic feature, but it is quite simple to understand. Okay, absence of lung markings cannot be absence of lung markings can technically be mistaken for a pneumothorax. Simple absence of lung markings is not sufficient to warrant the diagnosis, which means to say all other findings also should be present. Okay, what are the diseases that may mimic like a pneumothorax is bullous disease of the lung, or the large cysts that are present inside the lung will mimic like a pneumothorax, but it is not. But they will not have the visceral pleural line is not visible here, and there will be absent lung markings only. Okay, let's try to find out an X-ray. You see here, this is a bullous disease of the lung, but this is not a pneumothorax. Pneumothorax will actually look up as the visceral pleural line. Can you see the visceral pleural line here? No, the visceral pleural line is running perpendicularly to the chest wall and running perpendicularly towards the hilum. So this is not pneumothorax. In pneumothorax, yes, it has to be parallel, but this one is not. So this one I can see, even though there are absent lung signs, pulmonary markings, but I still don't say this as a pneumothorax just because I am seeing the chest wall pattern here not running parallel, but it is running perpendicular. So that is how I know this is a bullous emphysema. Okay, bullous emphysema is to say that there is a large cavity like area that is present with area of absent dead space. Okay, we call them as dead spaces. When we will try to do it when we are trying to deal about pneumonia and airspace diseases in detail. Okay, so this is called as a bullous emphysema. Is this concept clear now? How can I differentiate it between a bullous emphysema and a pneumothorax? It is just about the visceral pleural line running parallel or perpendicular. It is not always about the absence of a pulmonary marking, right? Okay, the next one you see here, well, compared to the same patient, you see here, the patient has a cystic space here, which is round in nature. And you see here, the pleural, visceral pleural is completely seen. It is quite close. Compare it on to the left, which has got a pneumothorax. You see here, this area is completely black. It is completely hyperlucent. You don't call it as radiolucent, okay? This area is not called as radiolucent. You call it as hyperlucent, appearing much more blacker than the grayish areas. Okay, see, it is called as a hyperlucent area. We can see a hyperlucent area, a rounded hyperlucent area inside the right upper lobe. But when compared to the, you know, irregular uh, hyperlucent area along with the visceral pleural line with absent lung markings, both of them has absent lung markings, but this is a bullous emphysema that is present here, but this is a pneumothorax that is present on the left side. Okay, that is, now I think you have understood what exactly I'm talking about. Is this clear? Yes, no? People, respond, please. Respond. Yes, bullous emphysema is round and it is actually running perpendicularly, but this is running parallelly. And you see here the visceral pleural line is present. And here you see here, is there any retraction of the lung towards the hilum? No, there is no retraction of the lung towards the hilum. But here on the left side, yes, there is retraction of the lung towards the hilum. So that's the reason I can say this is bullous emphysema, and I can say this is the pneumothorax on the left side, right? Okay. Now, there can be two types of pneumothoraces. One is actually called as a primary pneumothorax or the spontaneous pneumothorax, or the secondary pneumothorax as if or the tension pneumothorax that is actually happening in case of emphysema. Okay, so there are two types of pneumothoraxes. One is the tension pneumothorax and the spontaneous pneumothorax. I think you should have learned in it in pathology. There are two types of pneumothoraxes, remember, spontaneous pneumothorax and the tension pneumothorax. Pneumothorax is actually classified on the presence or absence of a shift of the mobile mediastinal structures such as the heart and trachea. The same thing generally happens. Simple pneumothorax is that there is no shift of the mediastinal structures. But there is a tension pneumothorax, we call it as, is that there is a shift of the mediastinal structures away from the side of the pneumothorax. Now, we will try to understand here in this picture, is this a simple pneumothorax or a tension pneumothorax now? Is there any shift of the mediastinal structures here? Is there is a shift of the trachea, or is there any shift of the mediastinal structure here? Is there any contralateral pushing? Yes, no, in this disease here, in this patient? Yes, no, no. So this one is a simple pneumothorax. Did you get it? Yes, Hisham? Yes, where did you find it, Hisham? Okay, maybe let us say this one. Sorry, this one. Yes, no. Even this picture. Yes, no. Exactly. Right. And this one. Okay, maybe I will show you bigger picture. We will try to understand. Okay, now you see here simple pneumothorax. This is a simple pneumothorax. You see here the trachea is centrally placed. Perfect. The heart, the right heart border is completely 1 centimeter away from the lateral border of the vertebra. Right, the left heart border is also looking quite fine here. There is no shifting of the hemidiaphragm. Okay, right hemidiaphragm is present higher, left hemidiaphragm is present lower. The costophrenic recesses are quite clear, but when I'm looking here, I can see that there is a more clearance of the rib shadows in the periphery. Rib shadows are more clear in the periphery. And I can also see, if I'm looking closer, I can see a thin visceral pleural line, and also the tongue is retracting towards the hilum. You compare to the area that is present here in the medial to compare to the density here. You see here, there is a compression atelectasis here. Yes or no? That's what we were talking before. Yes, right? This is the compression atelectasis that is actually happening here. All the bronchuses are brought together, and now that one is actually increased in density, and there is a lung which actually suggests that the lung is retracted towards the hilum. And you see here it has the apex and the base towards the pleural line, and now this visceral pleural line is running parallel to the chest wall, absent lung markings, and there is a hyperlucency over the rib shadows. Now all this one will tell me that this is a simple pneumothorax. No shifting. Did you understand now how I was able to interpret the pneumothorax? It is quite easy. It is not really difficult at all. Okay, right. You look here, but you see here in this picture, there is not the heart apex. You see here, midclavicular line is present somewhere around here, and the left apex of the heart is completely moving towards the vertebra. The left side of the heart is moving towards the vertebra, and the right side is getting more right. And now you see here, this one is actually this. You see here, this one is the compressed atelectasis. See, compressed atelectasis, and this one completely became like sandwiched in between. And now you see here, I see a thin visceral pleural line, and you see here larger area of the complete, see the larger area of complete posterior rib shadows, okay, are completely clear and they are devoid of pulmonary vascular markings. No pulmonary vascular markings are seen in this area. And you see here the trachea is quite closer to the mid clavicular line. See medial clavicular angle, right? See, that one is actually showing that there is a tracheal shift. So like yesterday when we were saying there is a contralateral tracheal shift along with the contralateral mediastinal shift will happen either in pleural effusion or a pneumothorax. And now this one is actually happening because of tension pneumothorax. Increase in the tension of the pleural cavity is called as a tension pneumothorax. Spontaneous pneumothorax, okay, right? A solid white arrow is actually the lung is lung is completely right, is collapsed. This one is actually happening as spontaneous. If it is happening suddenly, we call it as a spontaneous pneumothorax. Okay, this one actually spontaneous pneumothorax is actually happening. It is actually happening because of the rupture of the subpleural blebs or bulla. A bulla is completely collapsed. The thin visceral line is collapsed now completely. For example, we were talking about this area. Now this is a bulla, right? If this visceral pleural line is destroyed, you see here how thin this lung area is. Now let us say if this one is completely destroyed. Okay, now this one, what happens? All the air that is present in here start accumulating, and now this eventually will cause a complete pneumothorax. Okay, so that is what is called as a spontaneous pneumothorax. A spontaneous pneumothorax will happen because of the rupture of the subpleural blebs, remember, and it is characteristically present in tall thin males between 20 to 40 years of age. It can be traumatic also. The most common cause of a pneumothorax is either accidental or iatrogenic. Iatrogenic is that most of the patients coming down with the stab wounds, okay, that is accidental injury. And internal rupture of the bronchus from the motor vehicle collision, that is also accidental. And if we are trying to do a transbronchial biopsy, or we are going to do bronchoscopy, or if we are trying to insert a central line, okay, all these things, or when we are trying to do the cardioversion techniques, or when we are trying to do the CPR, all these conditions, okay, will eventually cause you a pneumothorax. Okay, try to learn if there is another condition which is actually called as pneumomediastinum. Pneumothorax is entirely different from a pneumomediastinum. Pneumomediastinum means to say the escape of air inside the mediastinal space. Mediastinal space means to say outside the parietal pleura also. Okay, we will talk that in cardiovascular system there, but it is not a pneumothorax. Okay, pneumomediastinum is entirely different from pneumothorax. Okay, pneumothorax is escape of air between the visceral and parietal layers. Okay, air can extend into the soft tissues of the neck, abdominal walls, and from the mediastinum, or it can dissect in the subcutaneous tissues from a thoracotomy, drainage tube, and penetrating injury. Okay, air dissecting along the muscle bundles and comb-like striated appearance also superimposing on the underlying lung, often making it difficult to evaluate the lungs by conventional radiography. So the confirmation or the extension of the subcutaneous emphysema and extension of a pneumothorax, the best investigation of choice is a CT scan. The number of the the number of the segments that have been collapsed by compression, counteractive compression, is the percentage of the pneumothorax. Now let us say if there is five or six segments that have been collapsed, so how much percentage of pneumothorax is present on that side? It is 60%. Did you understand it? There are 10 segments in each lung, right? There are 10 segments in each lung. Let us say each lung has got 10% of air capacity. Let us just for estimation purpose, okay? If each segment has got 10% of lung aerating capacity, how much, let us say, 5 or 6 segments have been collapsed. So how much pneumothorax is present? How much percentage of pneumothorax is present? There is 60% of pneumothorax that is present. Did you understand now? How are we calculating the effect of pneumothorax? How severe or not severe? Just it actually depends on how much percentage of the lung has been collapsed. Okay, right? So subcutaneous emphysema generally has no serious clinical effects, right? And they will take time to resolve. They will take several days to a week or longer to reabsorb. Okay, right? You see here, there is a lot of hazy density that is present over the subcutaneous tissue when compared to the normal X-ray. If we can remember the normal X-ray, we can see it, but this patient could have met with an accident, and there is a lot of subcutaneous emphysema that is present here. Okay, air dissecting along the muscle bundles that produces a characteristic striated appearance. You see here, right? Brachioradialis muscles, all the ones that they are actually looking up as striated appearance. All the muscles will show up as a fan-like structure. So that one is a characteristic feature of subcutaneous emphysema. Okay, subcutaneous emphysema. This one is actually the pectoralis major, teres major, and the teres minor muscle, and that has been affected. That one is escaped the air present below. Okay, right? So this one is a subcutaneous emphysema. All the air that has been present under the muscle now will show up the shape of the muscle as a fan. Okay, so that one is actually happening because of subcutaneous emphysema. All right. Okay. Right. So I think we have completed one of the 3 major chapters. The next bigger chapter what we have is a pleural effusion. Pleural effusion, yes, it is a little difficult, same like atelectasis to understand. It will take time. And after that, pneumonia, we have the bigger chapter. Another one is bigger chapter is pneumonia. That is what we have left. We have left with only 2 chapters uh, in respiratory system. We will complete off respiratory system by next week. Okay, next week, or let us say if I have a time, maybe along this Saturday or someday, we will try to complete off pleural effusion along with pneumonia. But since we have already completed the very basics, okay, all characteristic features, I think now it is getting more easier and easier for you. But it is confusing. It is not difficult. It is just confusing. Yes or no? Right? So did you guys all understand your topic today? Atelectasis, did you understand? Atelectasis is a little confusing, but it is not difficult. Okay, you can practice it. Okay, now since you have to remember all the basic radiographic feature from day one what we are learning. Slowly and slowly, when we are trying to put down together, we are trying to put down all this radiographic together, and we are trying to diagnose a disease. We haven't seen any diseases yet. Pneumonia is a disease. Pleural effusion is not a disease. Atelectasis is not a disease. Pneumothorax is not a disease. Okay. The only 2 diseases what we have seen is interstitial lung disease and bronchogenic carcinoma. Other than that, we did not see any other diseases. Yes or no? Tuberculosis we have seen, bronchogenic carcinoma we have seen, pneumonia we have seen. But atelectasis is a radiographic sign indicating of some kind of a disease. Bronchogenic carcinoma. Pleural effusion is a characteristic feature of some sign, some disease. It is indicating metastasis or tuberculosis. That's the same way pneumothorax is a condition that is actually indicating that has been a trauma, or the rib fractures. Rib fractures is a disease, right? Or bullous emphysema, rupture of the subpleural blebs, bullous emphysema. Emphysema is a disease. So these characteristic features of pleural effusion, these characteristic features of atelectasis, these characteristic features of pneumothorax occur together, and all together we will try to find out and conclude what is the disease. But we cannot just say it is only a pleural effusion, because there are millions of diseases that causes pleural effusion. There are millions of diseases that cause pneumothorax. There are millions of conditions that cause atelectasis. Did you understand why we are learning the basic diseases now here? The basic conditions, these are all the basic radiographic features which will eventually apply in later areas. Okay, so we will do this week pleural effusion also. I will try to complete pleural effusion and pneumonia by this week itself, so we can be happily going down to the next chapters. Okay, read all these chapters. I have completed till chapter 10. Okay, I did not complete the chapter 8 pleural effusion, okay, and chapter 9 recognizing pneumonia. I did not complete them. Okay, pneumonia is also a very fairly enough a big chapter, but it can be pleural effusion and pneumonias can be completed together. It is not difficult. It is very simple to understand. I will try to complete off by Saturday or so. Okay, if I find time, we will have a Saturday class. If not, we will not. Okay, I will try to find time there. Next week we will start cardiovascular system and we will be completing off this chapter for once. Is this concept clear for every day? Anybody have any doubts? Martin, Benedict, Novella, Brenda, Clara, Shweta, Arman, Shafiq, Hasham, Nitish Rai, Reshma, all people, right? Okay. Once we complete pneumonia and pleural effusion, we will have an assignment on this chapters. Okay. Until then, yes, you take time and keep reading. There will be tests only after we complete all these systems. Okay, pneumonia and pleural effusions are the ones that are left out. So maybe let us say most probably by next Tuesday or by next Monday we will have a test once we complete it. Do we still have pneumothorax? What do you mean by the etc topics? No, hemothorax. Yes, we will be dealing in about hemothorax in pleural effusion, Reshma. Okay. Hemothorax is the escape of blood inside the thoracic cavity. We will do that in pleural effusion chapter. Okay. Is your doubt clear, Reshma? Right. Hemothorax is escape of blood in the thoracic cavity. We will do it in the chapter of pleural effusions. Okay. Any others? Any others? Is there any doubt? Read these chapters. Most probably by next Monday we will have an exam. Okay, I will prepare a lot of MCQs for you to practice, and at the same point of time you will be given down an assignment to write down. Okay, so read beforehand. Okay, complete until these chapters what have been covered except for pleural effusions and pneumonias. Okay, don't worry about them, we will complete it later on. We will have a lot of MCQs and we will have an assignment to write down. Okay, sure, that's it for today. Okay, everybody have a nice time. Any doubts, just message me personally and I will try to deal with